mention that we've got a chat group where all questions can be posted. The topic of today, we've got two interesting speakers, and the first speaker I'd like to introduce is Dr. Ismail Sikandar Kala. Ismail is a senior consultant at Charlotte Macheke Johannesburg Academic Hospital. He's been a deputy head of pulmonology since 2018. Ismail completed his undergraduate training at Wits University and has completed his FCP in 2004. He also received the Escher Dub medal at that time. Ismail is well known to the IMA community and has given numerous lectures. Of note, Ismail completed his PhD in 2018, which we'll come back to later. Dr. Kala has been also involved in postgraduate teaching, has been involved in physicians' updates, and as well as has been a GMP coordinator. Ismail has received numerous prizes, including the T.H. Bothwell Research Prize. More on Ismail's PhD, which we can discuss later, Ismail. He looked into aspects of inflammation in patients with asthma. And I think he'll have a lot to teach us, and I don't want to go through his extensive CV. Of note, he also completed numerous publications, more than 30, was involved in numerous trials, and it will be a pleasure to listen to Ismail's lecture on the future of asthma management and the way to have more choice and better management and better control. Ismail would like to share your video, and we'd like to proceed first with the talk. All questions we'll have after both the speakers. Please post chats in particular on Ismail's topic, and later we will address the questions. Assalamu alaikum, Ismail, Dr. Kala.
Ahmed, while Ismail is sharing his slides, we will just have a short recitation from the Quran to kick off, as we usually do. So if everybody can just concentrate for a moment, then Ismail, sorry to delay you for a few seconds. أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم الحمد لله رب العالمين الرحمن الرحيم مالك يوم الدين إياك نعبد وإياك نستعين اهدنا الصراط المستقيم صراط الذين أنعمت عليهم غير المغضوب عليهم ولا الضالين صدق الله العظيم.
Ismail, can you unmute yourself?
Yes, Jazakallah Ahmed. I managed to unmute myself.
You should be able to share, Ismail. The sharing is open for you.
I'm going to, Jazakallah. I'm just going to share my presentation. Okay. Jazakallah Ahmed and Shoaib for asking me to speak on this most prestigious forum. For those of you who don't know, myself and Shoaib were actually in medical school together, and Ahmed was a co-registrar and then a consultant, in cardiology, right opposite the corridor in which I work. So I have a very personal relationship with both Ahmed and Shoaib. I know them personally very well. Jazakallah for the kind words, Ahmed. So in terms of basically, the gambit or the discussion for tonight from my side is going to be basically looking at asthma management. And there's been a significant paradigm shift in how we're looking at asthma management over the last 3 to 4 years. And what I'm going to go through is just the most important aspects with regards to the changes that have occurred in terms of asthma management, and try and leave you with 1 or 2 slides that will create some sort of an idea of what the future of asthma management will look like, but more importantly, where we've come from and where we're heading towards in terms of asthma. So as Ahmed mentioned previously, my doctorate was basically looking at inflammation in asthma. And when I started training as a doctor and then subsequently as a specialist, the inflammatory aspects of asthma were just becoming described, or were just at the forefront of their descriptive knowledge. A lot of my PhD was based on looking at biomarkers for asthma, and those biomarkers that I measured have now become the mainstay of measurement tools for our titration of asthma control. So I think when we speak about patients with asthma, the most important thing for us to understand is the terminology that we use, right? If we all speak the same language and we all understand what we're speaking when we're using certain terminology, it makes it so much easier for everyone to comprehend. And we have different people on this particular platform. We have pharmacists, we have physiotherapists, we have physicians, and then we have professors. So without being condescending to anyone, I just thought, one of the most important aspects for us to be able to enjoy the talk and to be able to understand and conceptualize what we're speaking about is for us to understand the terminology that I'll be using in this particular presentation. So the first and the most important thing that we need to understand is that, what do we define as uncontrolled asthma? And this is very easy for every one of us, right? And I'll show you how that particular aspect has changed. But I think basically it's just talking about patients who've had significant amount of symptoms or flare-ups of their disease process. And what's important for us to understand about the concept of uncontrolled asthma is that it's not our perception of asthma as such, but it's the patient's perception of their own asthma. So just let me explain that a bit carefully. If a patient has got what we call a cough variant of asthma, their exacerbation will be an increase in their coughing bouts, especially nocturnal cough. And they might not necessarily wheeze, or they might not necessarily have the classical symptoms that we associate with asthma, like the rhinitis and the shortness of breath. So each patient will present with an exacerbation that will be intimately linked to their underlying disease process. And as such, their exacerbations have to be interpreted with what their baseline level functioning was, right? So many of these patients, and if we look at the asthma pyramid, 95% of our patients are actually mild asthmatics, and their asthma could be well controlled with inhaled corticosteroids. The other terminology that we need to understand, and that's the difficult patient for us, is what we call the difficult to treat asthmatic. Now, as I mentioned, it's not necessarily the difficult patient in terms of the patient's perception, but it's a difficult patient because it's the one patient where, as you will see with the talk that I'm going to give, that our therapeutic options have become so vast. We've got so many different therapeutic options that it needs a bit of experience and a bit of guidance for us to choose the right therapy or the right intervention so that we optimize control in that particular patient, right? Asthma uncontrolled despite prescribing high dose preventive therapy is what we would classically associate with a difficult asthmatic, right? And of all the things that I've identified in my years as practicing as a pulmonologist, and most of you will be able to verify this, not even necessarily respiratory physicians, but even general practitioners, is that incorrect inhaler therapy and non-compliance are two of the biggest drivers for difficult to treat asthma. So in our clinics at Charlotte Mateke Johannesburg Hospital and Tusani Baragwanath Hospital, the first thing that we do when we are interviewing our asthmatic patient is ask them to demonstrate their inhaler technique. And it is amazing how many of our patients, despite being labeled as being asthmatic for more than 10 to 15 years, may have one or two nuances in the use of their inhalers that is incorrect. So I think it's vitally important for us to understand that. And then severe asthma. What do we classify as severe asthma? And you're going to see that severe asthma, the definition of it has changed. And more importantly, what it's now become understood that if we've got a patient on maximal doses of optimal therapy, those are the two things, maximal doses of optimal therapy, that means high doses of inhaled corticosteroids with a long-acting beta-2 agonist, and those patients are still having exacerbations, then that will be defined as severe asthma, right? The important thing about severe asthma is that our mainstay of therapy prior to 2016 was oral corticosteroids in these patients. But what we can see clearly now with the advent of biological therapy and with the advent of phenotyping is that we can now tailor the use of different medications so that we can try and reduce the use of inhaled corticosteroids, because it's very important for us to understand that corticosteroids come with a significant amount of collateral damage. So how do we differentiate severity versus control? And I think this is very important for us to conceptualize. Right? So you can be a severe asthmatic who is well controlled, and vice versa, you can be a mild asthmatic who's poorly controlled. And I think the most important thing for us to understand is that control has now become the key phrase in terms of therapeutic efficacy in asthma management. Right? Control is what we are all striving for. So asthma control is defined to the extent of which the various manifestations of asthma in the patient that's sitting in front of you have been reduced or removed by therapy. Right? So it's tailored to that particular patient. Whereas asthma severity is defined as the difficulty in achieving that control with therapy after the exclusion of modifiable therapy, modifiable factors like smoking, poor adherence, and definitely comorbidities. So one speaks to the amount of therapy that we need to gain control, whereas the other one speaks to the simple fact of loss of control independent of therapy that you're using. Right? So severity largely reflects the required level of treatment and the activity of the underlying disease state during treatment. So the more inflammatory therapy, anti-inflammatory therapy you need, the higher the burden of inflammation is within your lungs. All right. So why is it? Why have we come to this particular, understanding of asthma? How is this whole evolved? How is this paradigm shift in terms of our management of asthma evolved? And, when I was a medical student, one of the most important diagnostic tools that we had in terms of follow-up for our patients and in terms of managing our patients was spirometry. And everything was based on spirometry. If we could achieve normalization of lung functions, then that to us was the panacea. That was the gold standard. Those patients who achieved that particular therapeutic target had achieved control in asthma. All right. So what does that mean? That means that if you had corrected one parameter out of the multitude of different parameters that we have the opportunity of assessing, you would assume that the patients are controlled. And life is not so simple, right? And neither is asthma, unfortunately. And what this cartoon here clearly describes to us is it shows us that there is a significant proportion of patients who will have completely normal spirometry. Sorry, I just want to try and activate my laser pointer. So I don't know why it's not coming. I'm so sorry. Okay, but in any case, so you'll have these particular patients who will have normal lung functions, anything above 80% and up to even 120%, but they'll have a significant amount of symptoms. They'll still have their cough, they'll still have their wheeze, they'll still require their beta-2 agonist reliever therapy. And those are patients that we describe as overestimators. Right? They have a heightened perception of their asthma control. And in these particular patients, there might be an opportunity for us to wean the amount of therapy that we're using to achieve this control. Whereas there's a significant proportion of patients who will come into your clinic and will tell you that they are feeling absolutely fine. They've had no issues with their lungs. You'll sit down in front of them and speak to them, and they'll tell you for the last 3 months, they've been doing exactly what they've been in the previous 5 years of their life. And when you do a lung functions on them, you'll get a shock. You'll find that their FEV1 predicted is less than maybe, I would say, 65 or even sometimes 55%, which would clearly imply that those patients, because of their underperception of their disease, have actually gone on to remodel their airways and have now got what we would call fixed airway disease. So this is an important concept for us to understand. Furthermore, what's also important for us to understand is that asthma is now clearly identified to be a disease of the smaller airways. So what does that mean? That means that the capacitance vessels, or rather tubes in the lungs, are the main part of the lungs that become affected in asthma. And in this capacity, one needs to understand that you have to have a significant change in the diameter of the small airways for you to affect a change in a rudimentary measure like spirometry, right? So FEV1 and FVC will remain relatively normal despite a persistent amount of ongoing inflammation in those particular patients. So what we've understood and what we clearly can see from the studies that have been done is that asthma is a condition that is sometimes very difficult to assess. We have rudimentary tools that we're currently using, one being spirometry. And as I showed you, that in spirometry, we still have those patients that are misassessed because they are either under-perceivers or over-perceivers. And furthermore, the rest of our symptoms are based on subjective explanations by our patients. So we don't have a gold standard. It's not like blood pressure monitoring where you put on a BP cuff and you can see what the blood pressure is. And if you're still confused, then you do a 24-hour ABPM. Unfortunately, we don't have diagnostic tools, or rather tools that can monitor with that amount of accuracy the patient's lung functions or the perception of the patient's lung functions. And furthermore, what we've also known is that in the mild asthmatic, where one of our most important tools of asthma assessment, which is spirometry or rather peak expiratory flow, can be relatively normal. So we now classify those patients as being mild asthmatics. But how safe are the mild asthmatics? What in our mind, allows us to call a mild asthmatic and a mild asthmatic? And this is where the big misnomer has come about. And this is why one of my biggest, focuses on asthma on my PhD was looking at the biomarkers and the persistence of airway inflammation in what we previously described as the mild asthmatic. And what I clearly shown is that even in the mild asthmatic, there was a significant amount of ongoing persistent airway inflammation. And what we know is that in patients with apparently mild asthma, 37% of those patients had an acute asthmatic attack. So although they were mild, they still had a severe asthmatic attack that required an emergency medicine visit or emergency room visit. 16% of those patients who were classified as mild asthmatics ended up in ICU. And the most frightening statistics of all of this year is that up to 15% of patients in this particular cohort died. So I think asthma is not a benign illness. Right? Furthermore, exacerbation triggers are variable in patients. So we always like to assume that it's now come to that time of the year, or that season of the year where the weather is changing, where we're going to have pollen in the air, and our patients are going to exacerbate because of the high pollen burden or the high allergen burden in the air. But that's not necessarily true, because we see a significant divariant or diurnal modal or dimodal distribution to our asthma exacerbations. We see those patients who exacerbate in autumn, going on to spring, and as well as we see those patients exacerbating just prior to winter because of all the viruses that are exposed to, right? So we need to be cognizant of that. So there's no right season for asthma exacerbations, right? And more importantly, that our mainstay of therapy for the mild asthmatic has always been short-acting beta-2 agonists. So if you look at our previous GINA guidelines, and you look at basically step 1 in the management of asthma in GINA guidelines, although we had acknowledged that asthma is an inflammatory condition in the 1960s, was still to prescribe to our patients beta-2 agonists. So we need to understand that we did a lot of harm because of our lack of understanding of the pathogenesis of disease. The sad part about it is that we are perpetuating this crime because a lot of us colleagues and a lot of the people that I see, as well as the EDL in South Africa and the clinics, are insisting that SABA therapy be maintained in what they would classify as mild asthmatics. So I'm going to show you some slides about why that's completely flawed.
What's happened?
So the patient's perception that their relievers give them control over their asthma
Ismail, we've lost your sound.
Yeah, can you hear me now, sir?
Yeah, we can hear you. You are not muted on my side. We just lost it. I don't know why. Okay,
Okay,
you're
all
back now. Shukran.
Okay, all right. Okay. Was it for long? Did you lose me for a lot of slides, Shoaib?
No, like 10 seconds. 10
Oh,
seconds.
okay. All right. Okay, sorry about it. Okay. So basically, why have we had this shift in our assessment? Shoaib?
I can hear you, Isma. Yes.
Is there any way of muting everyone else and just keeping me unmuted?
Yeah, on my side, everyone is muted. So I think someone, and according to the settings, no one's allowed to unmute. So I don't know what's going on here, why people are unmuting, how it's even happening, because according to our settings, nobody's allowed to unmute themselves, and only if we allow them to unmute. So anyway,
All right, okay.
I think
no problem.
you carry on and then let's see. I don't know how that has been happening.
Okay, all right. Jazakallah khair.
Okay.
Right. So basically, the biggest problem with the use of SABA therapy is that it masks the inflammatory process because it's got no inflammatory anti-inflammatory component to it, right? And it's dished out like water because it's the cheapest inhaler that we have available to us. And it offers our patients a significant amount of instantaneous relief. We have to be cognizant of that. When the patients use their SABA therapy, they feel much better. And that is a negative reinforcement because the better they feel, the more they would want to use it. And unfortunately, the negative reinforcement with that is that there is ongoing persistent inflammation in the airway, and that airway inflammation becomes perpetuated. Right? Furthermore, beta-2 receptors downregulate the bronchoprotection and the bronchohyperresponsiveness from further use in beta blockers. So what happens is that if you continuously use beta blocker therapy, when you develop an acute exacerbation or a near fatal asthmatic attack and you end up in the emergency room, when we nebulize our beta-2 agonist, the therapeutic efficacy is blunted because of the downregulation of the beta-2 receptors. So that's another adverse problem with the use of beta-2 agonists. Right? And I think this is one of the most damning statistics that has come out in the last 10 years, is that the use of more than three canisters of beta-2 agonists, that means one beta-2 agonist canister prescribed every 4 months, is associated with an increased risk of emergency medicine presentations, and 1 a month is associated with death. So this has been published years ago. The first publication was actually by Suisa in 1994. And now again, with the MARCH strategy that's been implemented and the Sigma trials, we've seen again a significant re-emergence of this literature supporting the fact that SABA therapy is actually counterproductive and detrimental in our asthmatic patients. Right? And why is that? Why conceptually do we need to understand that SABA therapy is actually harmful for our patients? And the reason is simple. The reason for that, sorry, I just have difficulty here. So the reason for that is that our patients are much more in tune with their airways than we give them credit for. And they can anticipate an exacerbation before it becomes clinically measurable by us. So without the advent of significant biomarkers and micromolecules in the blood and the sputum, and looking at VOS markers, which is volatile exhale compounds, it's very difficult for us to predict an exacerbation. But if we rely on our patient's symptoms, they'll tell you that within a period of 10 days before the exacerbation became clinically significant, they actually felt a change in their airways. And what does a patient do if he knows that he's been diagnosed with asthma at this particular point in time? He introduces SABA therapy. The more symptomatic he becomes, the more SABA therapy he introduces. And that has nothing, it does nothing to abate this exacerbation, because you're not addressing the primary problem that's happening at this particular point, which is the initiation and then the amplification of the inflammatory process. And another important aspect for us to understand in asthma is that exacerbations beget exacerbations. If you have your first exacerbation, the likelihood and the odds ratio for you having another exacerbation within the next 18 months is almost 4 to 8-fold, depending on which literature you read. So if we look at our previous GINA guidelines, we're all familiar with this algorithm where we basically initially start with the assessment of the patient. We then introduce a therapy, and then we reassess the patients and then review the therapy. The most important aspect, as we can see, is that the bottom part of this algorithm, and it's the only part of the algorithm that goes across all 5 strata in asthma, the 3 main ones, step 1, step 2, and then 3, 4, 5, was as needed short-acting beta-2 agonist. So this was pre-2019 publication, which is not that long ago, 2 years ago. And subsequent to that, we've had 3 landmark studies. And what's important for us to remember is that these landmark studies were driven by one of the foremost pulmonologists and clinician pulmonologists in South Africa, Prof. Eric Bateman. So South Africa had a significant influence in the new asthma guidelines, and Prof. Bateman sits on the GINA Council. But this was his brainchild, or this is the brainchild, or the think tank that came up with these particular trials, was driven by one of our prominent South African pulmonologists. And what they looked at is inhaled combined budesonide formoterol, which is, for layman's terms called Symbicort in South Africa, as needed in mild asthmatic patients. So what does it mean? That if you've got a patient who's got mild asthma and you've classified them as mild asthmatic because their need for therapy is not that much, and you provide them with a therapeutic intervention that allows them to only use the therapy when and if necessary. So you don't give them a definitive regimen. You tell them, here's your asthma treatment plan, and if whenever you're feeling your chest tighten up, use this therapy for 14 days. You continue it for 14 days. And we found that in these patients, as needed budesonide formoterol provided superior asthma symptom control than as needed terbutaline. And terbutaline is basically a beta-2 agonist. And it makes sense that if we were to use a combination of an anti-inflammatory to treat an inflammatory condition, you'll get far better control. I mean, it's such a simple concept, and yet it took us such a long time for us to prove it because there was no industry-driven, support, and it got one of the best publications in the NEJM in 2018. All right. The second trial, which is the sister trial to this particular trial, was basically a trial of budesonide formoterol as needed for asthmatic patients. And here what they did was they kept the budesonide formoterol as continuous, not baseline. So it is basically in terms of a smart regimen. All right. And what they also found was that this sort of a regimen was superior to preventing exacerbations, right? And then this is the final trial, and these 2 of these trials, one is called the SMART trial, the other 2 are called the SIGMA trial, SIGMA 1 and SIGMA 2, was basically looking at as needed inhaled corticosteroid plus long-acting beta-2 agonist versus maintenance dose budesonide in patients for mild asthma. So what was the superior regimen? You could either tell your patient, maintain and use this inhaler for the rest of your life, or for the rest of the year, or for the rest of the next 6 months until I see you again. Or alternatively, here's the alternative. I'm giving you this other medication. Use this for 14 days when and if you're feeling sick. And what they found that in patients with mild asthma, budesonide formoterol use as needed was non-inferior to twice daily budesonide in terms of the rate of severe exacerbations, but was inferior to controlling symptoms. So what can we infer from this? What we can infer from this is that maintenance dose anti-inflammatory therapy is far superior than any form of reliever therapy. So in every patient, the baseline at the bottom, and these trials I'm going to show you now, have now become the baseline of our New Guinea guidelines. So it doesn't matter how you diagnose your patients. If you've got them on a regimen where they have some form of access to inhaled corticosteroids, that their outcomes are far superior than those patients where their maintenance and reliever therapy were discordant. Maintenance therapy was inhaled corticosteroids, reliever therapy was short-acting beta-2 agonists. What we've now suggested as part of GINA is that there must be concordance between maintenance and reliever therapy. And this we're all familiar with. We're all familiar with this new term. We call it MAT therapy, maintenance and reliever therapy. Before it was called SMART, but the S has been dropped because it held a connotation to a specific trademark drug, and we're now just calling it MAT therapy. All right. So do we have any literature to support the use of MAT therapy? Do we, am I saying this just because I want to say it, or have I got literature to support this? And what we can clearly see, and this is a nice cartoon that shows this, is that in patients who achieved asthma control, these were well-controlled asthmatic patients. When we attempted to reduce the inhaled corticosteroids, because there was a concern that such high dose of corticosteroids would impair and predispose patients to nosocomial, or rather community-acquired pneumonias, and that's still a significant signal, is that as we decrease the inhaled corticosteroids, we found that the patient's need for beta-2 agonists went up. Their objective measures of lung function dropped significantly, as well as their biomarkers, which is sputum eosinophilia and exhaled nitric oxide, also went up. So what this implied was that as we decrease the dose of anti-inflammatory therapy, we lost control of their airways, or the inflammation in their airways, right? So the increased inflammation associated with loss of control and the increased inflammation preceded the objective measurement of symptoms. And this here is important because this here alludes to the previous two slides that I showed you, where the patients started perceiving their airways as becoming tight, but we just didn't have the tools to measure it. Right? So what are now the goals of asthma therapy? The goals of asthma therapy is symptom control, which is the basically now become the gold standard. We want few or no asthma symptoms. We definitely want no sleep disturbances, and we want our asthmatic patients to live a completely healthy life. There must be no limitation in any form of exercise or activity. Furthermore, in terms of risk reduction, we want to make sure that we maintain normal lung functions. We prevent exacerbations because we know exacerbations beget exacerbations. And obviously, by controlling for these 2 years, we'll definitely prevent mortality and avoid morbidity from excessive therapy. Right? So this is what our goals of therapy going forward should be focused on symptom control and risk reduction. However, our patients might have different goals because they may want instantaneous relief. And that's where, again, beta-2 agonists come into this entire conversation. Right? So that's basically the first half of the talk. I'm just going to spend another few more slides looking at the latter part of the talk and the change in our management of our severe asthmatics. And what has been another significant innovation in terms of asthma assessment has been the advent of asthma endotypes and phenotypes. And this has been one of the major focuses, and it took up almost 80% of my doctorate, where I tried to subclassify and endotype asthmatic patients in South Africa and use different modalities to try and phenotype our patients. But just to give you a nice cartoon overview of what the asthma landscape is in terms of endotypes and phenotypes, the most important one for us to understand is that we have this on the one side, which is the Th2 high cytokine milieu, of which IL-4, IL-5, IL-13, and obviously IgE become part of it. And then we have the type 2 low. We don't call it the type 1 because the type 1 is a completely different animal in asthma, for want of a better word. Whereas the type 2 low is a highly treatable yet more refractory form of asthma. Right? Then we have the atopic or allergic asthmatic, who basically is the same asthmatic who presents with urticaria and eczema, and which will be part of the next talk. We have the asthmatic who develops his symptoms in childhood, And then we have the asthmatic who develops his symptoms over the age of 40. We have those asthmatic patients where we look at the blood results and we find that they have a significant eosinophilic aspect or in eosinophilia. And it's important for us to identify this because eosinophilia speaks to a Th2 high phenotype, whereas neutrophilia speaks towards a Th1 high phenotype, right? Then we have, just a few clusterings where we have the glucocorticoid responsive asthmatic. We have the asthmatic granulomatosis, which basically shows Strauss syndrome or basically eosinophilic granulomatosis. And then we have the patients who have smoking-related asthma or ACO, asthma COPD overlap. Inside here somewhere, and I'm missing it, you have the GORD-associated asthma, gastroesophageal reflux associated. But the most important one of all of this, and the one that I personally find the most difficult to treat, is the obesity-related asthma. And that asthma patient are really a disaster because they have significant limitations in their ability to maintain exercise capacity. They have a significant amount of comorbidities. They have a significant amount of reflux. And so the therapy is multimodality. And on top of that, then they have all the obesity-associated complications or lifestyle-associated complications with diabetes and hypertension. So asthma in these patients takes a backseat. And unfortunately, by the time we see these patients at our specialist clinics, they already have airway remodeling. And I'm not going to spend a lot of time on this slide, just suffice to tell you that there are over 100 different cytokines that have been developed for use in some form of compound to try and combat asthma symptoms. So basically, when we look at a cartoon of the inflammation in asthma, and this is important for us to understand because it gives us some conceptualization about where we are going with the advent of monoclonal therapy, is that we have basically the eosinophil. The eosinophil is basically driven or immortalized by IgE, which causes the, immortalized by IL-5 and IL-4. We also have basically the B lymphocyte, which becomes switched under the guidance or under the stimulus from IL-4 and IL-5 to become IgE producing. The IgE then serves as a surface cell receptor on mast cells and causes mast cell degranulation. So in each of these different aspects, there's some company that's trying to produce a biomarker to block some part of the asthmatic airway response. And other than the 100 cytokines and chemokines that have been developed, there is an active amount of research going into looking at pathological subclassifications of asthma phenotypes. Right? So, as I said, the most important aspect of asthma that we need to understand and that we're going to be using going forward, and the easiest one for us to basically understand, risk stratify, and introduce a treatment strategy for is basically what we would classify as the eosinophilic asthma or the Th2 high asthmatic, right? And that's defined as basically a high eosinophil count, a high pheno, a high amount of FEV1 reversibility, allergic status, as well as asthma associated with atopic dermatitis and rhinitis and nasal sinusitis and polyposis. Right? And when we look at these particular slides, we're looking at basically exacerbation risks as a function of pheno and eosinophils. And what we can clearly see is that both fractional exhaled nitric oxide as well as eosinophils were important in terms of identifying those patients that will have exacerbations, and not only were when titrated for therapeutic efficacy. So all you did is you look at these two biomarkers. I'm going to treat your asthma based on your pheno level and your sputum eosinophil count. We found that if those were the only two parameters that were used, then asthma control was actually superior in these two cohorts as compared to our conventional assessment tools for asthma. So where's all of this come about? This all led to this publication of the second part of that, let me rephrase it, the sixth part of the GINA guidelines, which is basically the GINA guidelines that speaks to and discusses refractory asthma. Right? And when we look at basically refractory asthma requiring what I would say highly specialized clinics for patients to be managed in, then we're talking about the introduction of biological therapies. And what we clearly know is that we have anti-IgE, anti-IL-5, and anti-IL-4, IL-13. So these are the three major cytokine molecules that are targeted by antibodies against these particular antigens, right? And thus, in mopping up these particular antigens, seems to modulate airway inflammation. And what we can clearly see, the drugs that have already been developed are basically dupilumab, which blocks IL-4, IL-13, mepolizumab, reslizumab, and benralizumab, which are basically blocking the IL-5 cytokine pathway. We then have the IL-4, IL-13 as well in the bottom part of the pathway, which is dupilumab and lebrikizumab. And all of this here orchestrate basically the subendothelium as well as the surface cells milieu. Right? If you want to target below this, what we would call downstream markers, then we have to look at basically other forms of trying to break this particular cytokine by introducing drugs like montelukast and other small molecules. But more importantly, if we haven't achieved control with all of this, then we need to think out of the box. And how do we think out of the box? We think out of the box by trying to break the basal membrane that forms in our asthmatic patients, which is by use of bronchial thermoplasty. Right? So when we look at basically how do we target our asthmatic patients, our targeted therapies are directed predominantly at a certain phenotype. This phenotype speaks to a biomarker, which we can then use to titrate or choose a specific therapeutic intervention. And this is my last slide. And I'm sure all of us are familiar with the boxed approach to our management of our COPD patients, which is basically part of the GOAL guidelines, where if we're going to move towards the future of asthma therapy, which is individualized therapy, that means choosing of drugs based on the patient's biological footprint or asthma biological footprint, then this is what we're going to be basically looking at. We're going to be looking at eosinophils and exacerbation risks, and then choosing whether the patients fall into a high or low risk category, and then deciding what therapy to offer these patients based on their phenotype. Thank you.
Shukran, Ismail. Thank you for that excellent talk. While we, Shoaib, while you can put on the next advert from the sponsor, we'd like just to mention if any questions the audience would like to discuss with the speakers, we'll address the questions at the end of the program. You could message me privately, which I have been receiving a few questions. And we also ask for the audience to raise their hands at the end of the second speaker. Shoaib, do you want to put up the second or just the sponsor's video, and then we can move on to the second speaker.
Okay, let me stop sharing.
Could you hear the sound, Amit? Could you hear the sound when I played it?
I can't hear the sound, Shoaib. Let's try again.
I said it's playing on my side. Let me try and stop it. Let's try again.
I think it's a short video, Shoaib, so let's let it proceed for a minute.
Can you still not hear it, Amit?
Still can't hear it.
Okay, let me stop it and we'll try it again. I'm not sure why it's not playing. It worked when we tested it the other day, but it seems to be something different this time. I don't know. Okay, maybe carry on, I think, and we'll try and play to the end again.
So the second speaker is Dr. Ahmed Manjra. Dr. Manjra works at Westville Hospital in KwaZulu-Natal. He completed his MB-BCH in 1983 and completed his pediatric degree in 1988. Dr. Manjra is well known to the community, and of note, he did an allergy diploma in 2003 where he got a gold medal. Of note, he's a fellow of the American Academy of Allergy, Asthma, and Immunology, as well as the European Society. Dr. Manjra has been the past president of the Allergy Society. Just as Ismail has done numerous publications, numerous trials, has been a PI of many trials. He's done more than 60 publications and is really one of our country's lead experts in allergy management. I'd like to welcome Dr. Ahmed Manjra. Dr. Manjra, can you put your video on? I see you are unmuted.
Okay, can you see me?
That's perfect. Your video is showing excellently. Thank you very much. And just to note for the audience, we'll address all the questions at the end of Dr. Manjra's talk. Thank you for giving us your time, Dr. Manjra, and we look forward to your presentation.
We just put the video on. Sorry, 1 second. Okay. A'udzubillahi minasyaitonir rajim. Bismillahirrahmanirrahim. Assalamu alaikum wa rahmatullahi wa barakatuh. I'd like to thank the IMA for giving me this opportunity to speak to you about a very common problem that we see, and that's of urticaria. And the title of my talk is It's More Than an Itch. And I'm going to try and focus on some of the recent advances in the management and our understanding of urticaria. So the disclaimer slide is that the views that are expressed in this talk are entirely mine. And the pharmaceutical company that's sponsoring this meeting does not necessarily share my views. I have no disclaimers. I don't have any vested interest in any pharmaceutical company. So I'm going to speak about the epidemiology of urticaria, the pathophysiology of urticaria, the affectation of quality of life, the different types of urticaria, and the management of urticaria, and as well as the recent advances. Now, we always think that urticaria is a very minor problem, and it's only few people that are affected by urticaria, but it's actually much more common than we think. It's estimated that, I need to get back to that slide, sorry. Let me go back, I'm trying to go back. I don't know what's happened here. Sorry about that. So anyway, it's much more common than we think. It affects 1% of the population at any given time. And the female to male ratio is 2 to 1, but all groups can be affected, and the peak incidence can be between 20 and 40 years of age. There is no apparent relationship between urticarial prevalence, educational background, income, occupation, place of residence, or ethnic background. And this has been clearly shown in many studies. And there is evidence that suggests that the prevalence of chronic urticaria in particular may be increasing. And certainly in my experience, I certainly am seeing much more patients now than I've previously seen with chronic urticaria. Now, various cells are involved in the pathogenesis of urticaria. We know that basophils, neutrophils, eosinophils, and T lymphocytes are involved. But the main effector cell that's involved in urticaria is actually the mast cell. And in fact, some of us think that chronic urticaria in particular may be a manifestation of a mild form of mast cell activation syndrome. A severe mast cell activation syndrome presents like mastocytosis. They have systemic symptoms which affects multi-organs, but a mild form of mast cell activation syndrome may give you only urticaria as the only presenting sign. So we know that mast cells have preformed as well as newly formed mediators, and in the hierarchy of mediators that cause symptoms, you know that histamine is the main one, followed by tryptase and leukotrienes, and there are hundreds of mediators, and every time you open a journal, you read about a new mediator that's been found in the mast cell. Now these mediators, they activate the sensory nerves, and mast cell activating signals in urticaria in particular stimulate the sensory nerves, which is why patients experience significant pruritus in these patients. We also know that as in asthma, as alluded to in the previous talk, that IgE is key to the release of histamines and other pro-inflammatory mediators from mast cells and basophils after degranulation. And this may play a significant role in chronic spontaneous urticaria. And this has very important therapeutic implications as well. So the underlying pathophysiological mechanisms in urticaria is that you get cross-linking of IgG antibodies, which is an autoantibody, which then cross-links with the IgE, which then binds to the receptor on the mast cell. This then leads to mast cell degranulation. And there are different types and different types of autoantibodies that have been recognized in patients with chronic spontaneous urticaria. And this also has important therapeutic implications because certain patients respond very well to anti-IgE therapy and certain patients don't respond well to anti-IgE therapy. So there are many different mechanisms. Sometimes you get cross-linking of mast cells directly with the antigen. Then you get autoantibodies and you get different types of autoantibodies as I've alluded to. And this then causes symptoms of urticaria such as hives, which most of you are familiar with, and can cause itching, and this causes significant affectation of quality of life. It can cause reflex erythema as well as angioedema. So in summary, basically, patients with chronic spontaneous urticaria have a significant autoimmune component to the disease. About 55% have an idiopathic etiology, and in fact, allergy is a very small component in the causation of chronic spontaneous urticaria. And there are various different types of autoantibodies that have been demonstrated in patients with chronic spontaneous urticaria. So as I've mentioned in the title of my talk, that this is much more than an itch, in that chronic spontaneous urticaria significantly affects the quality of life of patients. And this has been found in many studies. It affects the daily living of patients, physical activities. They're unable to do some of the common chores. It affects the eating, the concentration. Many kids that have this particular disease have significant problems with concentration in school. It affects their learning behavior. And the worst symptom that's affected is the affectation on sleep. So these patients have significant problems with sleep. Many of them are hooked on sleeping tablets because they're unable to sleep because of the itching that's associated with chronic spontaneous urticaria. A lot of these patients are on antidepressants, on anxiety drugs, on anxiolytics. They are constantly tired, they're stressed, they're overwhelmed. This affects their ability to do their work. It affects their employment. It impacts on the relationship. It impacts on their spouses. They also have a restriction on the type of clothes they wear. It affects their hobbies. Many of them avoid the sun. And we know that some of the treatments that are associated for the treatment of chronic spontaneous urticaria themselves can have side effects. And many of these patients have lots of psychiatric problems, loneliness, anxiety of the future, and they also feel like there's something significantly wrong with the immune systems. So studies indicate that the quality of life scores in patients with chronic idiopathic urticaria and chronic spontaneous urticaria are similar to or worse than those in many other diseases, even those that are much more serious in urticaria. So it's been found in studies that quality of life is worse than in patients with psoriasis, with atopic eczema, with basal cell carcinoma, and it's even been compared to leprosy. The quality of life scores for energy, social isolation, emotional reactions are very similar to those in patients waiting for bypass surgery. So these patients experience significant amount of psychiatric and psychological problems. And then, of course, the socioeconomic cost of chronic spontaneous urticaria is very high in terms of the direct medical costs and the indirect costs, such as lost wages because of absences from work. Now, it's not only absence from work, but it's also a concept called presenteeism, where patients go to school and go to work, they're there, but they are unable to perform their tasks. And this is a significant problem in patients with urticaria. So how do we classify urticaria? There are two broad categories of urticaria. There is chronic urticaria and acute urticaria. And the differentiation between acute urticaria and chronic urticaria is based on the duration of symptoms. If your symptoms are less than 6 weeks, then it's called acute urticaria, where the pathophysiology is different and the treatment is very different, and the duration of the disease and the prognosis is very different. Chronic urticaria is when symptoms occur on a regular basis, almost daily, for more than 6 weeks. Now, there are two types of chronic urticaria. There's a type of chronic urticaria called inducible urticaria, which in the past we used to call physical urticaria. And in these group of conditions, the symptoms are triggered by a specific trigger, such as heat, water, cold, pressure, sweating, or just direct stroking of the skin. And we'll talk about each one in a little bit more detail later in my talk. Now, if it's chronic urticaria and if it's not inducible, then it's called spontaneous urticaria. And the new term that we use for urticaria now, for chronic urticaria, is chronic spontaneous urticaria, or CSU. So chronic spontaneous urticaria can be defined as the spontaneous daily or almost daily occurrence of itchy hives, angioedema, or both, lasting for 6 weeks or more. Now, I just want to talk very briefly about the differentiation between urticaria and angioedema. So the pathological and pathophysiological mechanisms for histamine-induced angioedema and urticaria is the same, because you can also get angioedema, which is bradykinin-induced and not histamine-induced. So when your superficial layer of the skin is affected, when your epidermis is affected by the effects of the mast cell mediators, you get urticaria. When the same type of inflammation gets deeper into your skin, then and when it affects the dermis and the subcutaneous tissues, you get angioedema. So urticaria and angioedema are both sides of the same coin. One affects the superficial layer and the other affects the deeper layers. Now, one must also learn to differentiate between the different type of angioedemas, because you get histamine-induced angioedema and bradykinin-induced angioedema. An example of bradykinin-induced angioedema is the one that's induced by ACE inhibitors, that's used for hypertension and cardiac problems. So acute urticaria affects 20% of people at some times in their lives. About 80 to 90% respond to antihistamines, and about 10% may need steroids, and it's also associated with angioedema. Inducible urticaria, 80 to 90% respond to antihistamine, except in patients with pressure urticaria or deep pressure urticaria, who sometimes don't respond very well to antihistamines. And some of these types may be associated with angioedema as well. Now, chronic spontaneous urticaria affects about 1% of the population. About half of these patients respond to antihistamines, and some of them respond only to high doses of antihistamines, but even then, only about 50% respond to 4 times the dose of your licensed doses of antihistamines. And about half of these patients also have angioedema. So when you take a history from these patients, it's important to find out about the timing of their attacks, the frequency of the attacks, the duration of the attacks, the shape, the size, the distribution, associated symptoms, the family history, the medical history, particularly about autoimmune diseases such as hypothyroidism, lupus, rheumatoid arthritis, because these are often associated with chronic spontaneous urticaria. If there's any correlation to triggers such as foods or infection, or different types of physical triggers such as temperature, swimming, we get a type of urticaria called aquagenic urticaria, which is an extremely rare form of urticaria. Or if it's associated with certain type of work, hobbies, smoking habits, stress, and what the response to the therapy. So these are some of the questions that we ask patients. And the most important way in elucidating the cause of urticaria in these patients is by taking a good history. And very few of these patients need special investigations. Now, there are many skin rashes that mimic urticaria, what we call pseudo-urticaria. And in children, these are very common maculopapular exanthems, such as roseola, from viral infections, fixed drug eruptions. Then there's a type of urticaria called urticarial dermatitis, erythema multiforme, in Durban, we see a very common form of urticaria called papular urticaria, which is caused by insect bites, mosquito bites, fleas, as well as bird lice. We see it particularly during the summer months in Durban. And there's a very a sinister type of urticaria called urticarial vasculitis, which is often associated with underlying tumors and malignancies. It's called leukocytoclastic vasculitis. That's a pathological type of definition, which is a particular type of urticaria, and we don't have time to go into it. And then you get a type of urticaria, urticarial-like eruption called polymorphic light eruption. And then some autoinflammatory diseases like knuckle valve can also mimic types of urticaria. So let's just talk very briefly about urticaria. It's more common in children. We see it almost on a daily basis. We get an abrupt onset of an urticarial reaction, which is usually very pruritic. It's widespread. Angioedema is common. And most commonly, this is associated with the viral infections. And this can occur during the prodromal phase of the viral infections, at the acute phase of the viral infection, and sometimes even 2 or 3 weeks after a viral infections. The duration is usually hours or days. The causes can be, as I've mentioned, viral infections in adult patients, usually associated with non-steroidal anti-inflammatory drugs, penicillin, radio contrast media. With radio contrast media, it's non-IgE mediated. In these patients, you get direct mast cell degranulation by the radio contrast materials, depending on what they use. We often see acute urticaria associated with foods. And in children, it can be milk, egg, wheat, soya, fish, and peanut. In adults, it can be fruit, it can be peanuts, and it also can be seafoods. There's also a non-allergic type of urticaria caused by foods such as cromboid fish poisoning and other forms which we don't have time to go into. And of course, something that we've seen very recently is urticaria caused as a result of immunization. We've seen this with MMR, with tetanus toxoid, and I've seen numerous patients now developing urticaria as a result of the COVID vaccine. And this has been very well documented in the literature. Now, none of these patients with acute urticaria require any investigation because the cause is usually evident both to the patient as well as the doctor alike. Skin prick tests are unnecessary and are to be avoided in patients. And definitely blood testing should also be avoided unless there's a very clear history of an association with food or with drugs. Then your either immunocap RAS testing or your CAS testing can be done to find the culprit causing the urticaria. So let's talk about, so that's acute urticaria. Now remember I mentioned there are two types of chronic urticarias, the inducible urticarias and the spontaneous urticarias. I'm going to talk very briefly about the different types of inducible urticarias. So the most common type that we see in practice is called symptomatic dermatographism. It's also called factitious urticaria. You get delayed pressure urticaria, cholinergic urticaria. The less common type is cold contact urticaria, and the very rare types is solar urticaria, heat contact urticaria, aquagenic urticaria. This occurs in patients who, when they swim and they get into cold water, either fresh water or seawater, they develop acute urticaria. And unfortunately, this significantly limits their ability to swim. And that can be, of course, a disaster in places like Durban. We also get a type of, a rare type of urticaria called vibratory angioedema. So I'm going to go into some of these very briefly. We don't have time to go into all of them. But some of the common characteristics of inducible urticaria, except delayed pressure urticaria, is that the urticarial lesions usually last for less than 2 hours. There are various tests you can do in the rooms, which are very simple tests, such as ice cube tests, exercise testing, or scratching in patients with dermatographism. And most of these don't have a late reaction. They usually are easily treated with antihistamines and sometimes may require high doses of antihistamines, and very rarely do they respond to corticosteroids. Now, symptomatic dermatographism, and this is a picture of a patient with symptomatic dermatographism. It's a very common physical urticaria we see in patients. And sometimes you get patients with very mild forms of symptomatic dermatographism, which they have absolutely no lesions on the skin, but they come in complaining of chronic pruritus of the skin. You find absolutely nothing. Their liver function is normal, their kidney function is normal. They actually respond very well to high doses of antihistamines, basically then demonstrating that histamine release plays a very important role So I think many of these patients have a very mild form of symptomatic dermatographism. And when you do what we call a Frick test is when you take a special instrument that we've got to demonstrate dermatographism, many of these patients have a positive Frick test. They have generalized pruritus and wheals, and that's aggravated by scratching, rubbing, tight and coarse clothing. Also commonly seen in young infants. Many of these patients are fractious. The kids cry all the time. And when you examine the kids, they have these red wells when you examine them. So many of these young infants who are misdiagnosed as colic actually have symptomatic dermatographism. In these patients, the mucous membranes is unaffected, and very rarely do we find these patients have angioedema. So this is a picture of a patient where you can just easily demonstrate that they have symptomatic dermatographism. So these are some of the characteristics. They complain of itching, an insect crawling under the skin, and they get a worsening. The more they scratch, the worse the symptoms become. It's particularly prominent over pressure points where the clothing is tight or rubbing of the skin. Sometimes, very rarely, you can get lip swelling. And when severe, it may be confused with other types of chronic urticaria as well. The type that I see quite commonly is a type called cholinergic urticaria. Just to show you a picture of cholinergic urticaria, it's characteristically different from your normal urticarias that you see, in that they have very small punctate lesions on the skin, extremely pruritic. They are transitory, they are symmetrical, and it looks like a red maculopapular rash. It occurs usually on the neck, on the limbs and the trunk, and it occurs after exercise, heat, or emotion. And what's been found in these patients is that they're actually allergic to their own sweat. There's an antigen that's found on the sweat, and these patients produce IgE antibodies against their own sweat. So sweating these patients induces this form of cholinergic urticaria. And in some centers overseas, they do immunotherapy with the patient's own sweat, and that's been found to work significantly in these patients. We haven't gone down to that point yet. Sometimes in very rare patients, they may also have bronchospasm, which may mimic a type of anaphylaxis in these patients. So this is a picture of a patient with cholinergic urticaria. And when you see it, it's very, very characteristic, very easy to make a diagnosis when the patient takes a picture of their skin and brings it to you. Because most of the time when you see the patients in your practice, all these lesions are gone completely, as Murphy's Law goes. Now, characteristic of cholinergic urticaria, it usually begins in the neck, trunk, and spreads to the faces and extremities. It's sweating, which can be induced by exercise, hot showers, eating hot, spicy food, can trigger off cholinergic urticaria. As I've mentioned, many of these patients have small urticarial lesions, and histamine release has been demonstrated in these patients as well. I'm going to skip this slide because I think a lot of it is repetition. Then you get a type of urticaria called cold urticarias. And these patients experience urticaria when they get into cold temperatures. It affects commonly people that work in supermarkets and butcher shops. When they get into a cold room and their body temperature drops, they get significant urticaria. And in some of them can even get anaphylaxis, and these can be life-threatening reactions. Extremely rare, but we see them every now and then. It occurs predominantly on unclothed areas, your hands and your face, and it can be associated with anaphylactic reactions in patients who swim in cold water. So again, very difficult condition to treat, very challenging to treat these patients because many of them are swimmers and sports people, and they actually demand some sort of therapy. So this is a patient with cold urticaria where we demonstrated it by using an ice block test. We place an ice block on the volar aspect of the forearm, and within minutes you see an acute urticarial reaction on their skin. So these are some of the different types. We don't have time to go into all the different types of urticaria, but you can see the inducible urticarias, the cholinergic urticaria, dermatographism, delayed pressure urticaria, cold urticaria, solar urticaria, exercise-induced urticaria. There are various types of tests that are done for these patients. In cholinergic urticaria, it's very simple. You make them go for a short run and they come back full of wheals and flares. Dermatographism, the most common way of demonstrating is by stroking of the skin with a tongue blade. We've got a special device called a Frick test, F-R-I-C-K, which specifically demonstrates dermatographism in patients. In delayed pressure urticaria, there are specific protocols to follow to demonstrate it. Cold urticaria is very easy. You put an ice cube on the forearm, and within 5 minutes, you get a wheal and flare reaction. Solar urticaria occurs on exposure to specific wavelengths of light. There are special machines for this. So many of these can be demonstrated using very simple tests. So if it's not acute urticaria, if it's not inducible urticaria, then it's a type of urticaria called chronic spontaneous urticaria. Now, if you forget everything else that I told you, and just remember this slide, you will be doing a great favor to your patients. Because what I see is patients who have chronic urticaria have lots of blood tests done, numerous investigations, and very rare do these investigations yield a particular cause in these patients. Chronic spontaneous urticaria, it means urticaria that occurs almost daily for more than 6 weeks, is never ever caused by a food allergy. Please don't do food allergy tests. It's an unnecessary expenditure for patients, and it invariably will come back negative. And if it's positive, it's usually a false positive reaction. Patients then go on to exclusion diets with very little symptom relief. There were some articles many years ago about the link between Helicobacter pylori and its association with chronic spontaneous urticaria. It's only found to be an association. Even complete eradication with triple therapy or quadruple therapy for Helicobacter does not treat patients with chronic spontaneous urticaria. Stress is not a cause of chronic spontaneous urticaria. Many patients, their symptoms may be aggravated by stress, but it's not a cause. Drug allergy, many of these patients have other chronic diseases, and many of them stop their medicine because they think that's the cause of the urticaria. It's not drug allergy, and of course, it's not environmental pollution. So moving from one province to another, or from one house to another, will not give these patients any symptom relief. So these are not the causes of chronic spontaneous urticaria. What we do know, however, is that many conditions and many substances can aggravate the problem. And one of these is non-steroidal anti-inflammatory drugs. So a significant percentage, 20 to 30% of patients with CSU, chronic spontaneous urticaria, develop anaphylaxis to non-steroidal anti-inflammatory drugs. Sometimes pseudoallergens in foods can also trigger off or make it worse. We know consumption of alcohol makes it worse, intercurrent viral infection makes it worse, and stress and work stress can also aggravate chronic spontaneous urticaria. Now, we know that a significant percentage of these patients have angioedema as well, which usually affects the eyelids, lips, and tongue. Although it's very alarming, no patient has ever died from angioedema in these patients. It's not the angioedema that we see in hereditary angioedema, where you can get airway obstruction and can lead to death, or it's in fact a fatal condition. The histamine-induced angioedema that we see in chronic spontaneous urticaria is never ever fatal. 50% of patients with chronic spontaneous urticaria have concomitant inducible urticaria as well. So a large percentage of these patients have all those different categories of inducible urticarias, which can be quite a difficult thing to unravel when they've got different types of urticaria, a combination of CSU as well as inducible urticaria. And we know that functional thyroid disease, either hypo or hypothyroidism, occurs in about 20%, and Hashimoto disease is found in 15% of patients with chronic spontaneous urticaria. Now, once again, in patients with chronic spontaneous urticaria, it's completely unnecessary to over-investigate these patients. Some of the basic investigation that you may do to exclude serious underlying diseases, maybe an FBC, a CRP, and an ESR. You may want to do a thyroid body antibody test to demonstrate an association between other autoimmune diseases. And rarely in patients with poor response to antihistamine, a skin biopsy may also be performed to exclude urticarial vasculitis. Now, we know that the autoimmune component in these patients with chronic spontaneous urticaria is a very predominant one, in that antibodies are seen in 40% of these patients. Antibody to IgE is seen in 5 to 10% of these patients. Antibody to the alpha subunit of the high affinity IgE receptor is seen in 30 to 40%. Anti-thyroid antibodies is seen in 25% of patients. Your ANF is seen in 30% of patients. And as I've mentioned earlier, there's a significant association with autoimmune thyroid disease as well. Now, one of the tests that we do, which is quite a simple test to do in your rooms, in patients with chronic spontaneous urticaria, is called an autologous skin prick test. So what we do here is we take a blood sample from the patient with urticaria. Of course, they need to follow the protocol in terms of avoidance of antihistamines and steroids. We then spin the blood, we take the serum, and we do a skin test with their own serum. And if they've got autoantibodies to IgE, you see a wheal and flare reaction as you see now. So this is a positive autologous skin test. It's free, it doesn't cost the patient anything. It's a very simple test to demonstrate autoantibodies in these patients. So the management of chronic spontaneous urticaria is, of course, avoidance of triggers. I've mentioned all the triggers, and you can see them on the slide as well. So avoidance of triggers is very important. And the first line treatment in these patients is your second generation antihistamines, not the first generation antihistamines. So your classic antihistamines, such as your chlorpheniramines, which are commonly found as OTC products, are not advocated for use in these patients because they have significant side effects. They are not only antihistamine, but they also have anti-serotonin effects and anticholinergic effects, can lead to dry mouth and drowsiness, and can affect work performance and school performance. So we don't advocate the use of the first generation of antihistamines, we advocate the use of second and third generation antihistamines. So the first generation antihistamines are not recommended because of the associated side effects, but the modern second generation antihistamines are well tolerated by most patients. So when you look at your first generation of antihistamines, 90% of your patients will experience somnolence, drowsiness, tiredness, fatigue, and so on. With your second generation antihistamines, because they don't cross the blood-brain barrier and they don't have anti-serotonin activity and anticholinergic activity, most of them do not experience side effects of tiredness and somnolence. However, there are a small percentage of patients, about 10%, that may experience these side effects, the mechanism of which is unknown. So the majority of these patients do not have any side effects, and therefore they're very safe to use in patients with chronic spontaneous urticaria. Now, 50% of patients with chronic spontaneous urticaria will respond to your second generation antihistamines at licensed doses. And that's a big problem, which means the other 50% are not responding to antihistamines. What we do in these patients is we give them 4 times the licensed dose of second generation antihistamines. Now, obviously, you can't do this with your first generation antihistamines because of the association with side effects. But with second generation antihistamines, it's been clearly shown in many studies now, studies after studies, that using 4 times the dose, your package insert doses of your second generation or third generation antihistamine is absolutely safe. It's been suggested that the increase in dose not only blocks the histamine effect, but it also has a mast cell stabilizing effect and has an impact on the release of cytokines as well as adhesion molecules, which play a very prominent role in the pathophysiology of chronic spontaneous urticaria. So even in these patients where you updose the dose of antihistamines to up to 4 times the dose, about 30% of these patients do not respond to 4 times the dose of antihistamines. What do we then do with these patients? So the guidelines that were published in 2009, and of course with the advent of omalizumab or Xolair, which is an anti-IgE antibody, the guidelines suggested that your first line treatment is your licensed dose of second generation antihistamine. If that doesn't work, as we said, in 50% of patients, you may have to give them 4 times the dose of antihistamines. If, of course, only 30% of patients will respond to 30% of patients will not respond to 4 times the normal dose. The suggestion was to give a leukotriene receptor antagonist or another type of non-sedating antihistamines. And then, of course, they added on cyclosporin, dapsone, and omalizumab. And that was when omalizumab was just being studied. There were trials being done with omalizumab, which is an anti-IgE monoclonal antibody. However, these guidelines have been revised, and the 2013 guidelines place omalizumab as your third-line treatment. So first-line treatment is licensed dose of antihistamine. Second-line treatment is 4 times the dose of antihistamines. And of course, once a patient is doing well, you can down titrate the dose. And if 30% of these patients don't respond, then they should be treated with omalizumab as a third-line treatment. And if the patient doesn't respond to omalizumab, they will respond to cyclosporin or sometimes even montelukast. But the response to montelukast has been a very poor response in patients with chronic spontaneous urticaria. So these guidelines have been further amended in 2017 and very similar to the 2013 guidelines, where they make omalizumab not on par with cyclosporin, but make it the third-line treatment, and they make cyclosporin the fourth-line treatment. So first-line treatment is licensed dose of antihistamine. Second-line treatment is 4 times the licensed dose. And if these patients do not respond, then you add on omalizumab. We'll talk about the dose of omalizumab and how it's used. And then you add on cyclosporin if patients do not respond to omalizumab. So about 80% of patients respond positively to omalizumab with significant amelioration of their symptoms. But 20% of patients don't respond because they probably have a different type of autoantibody. And these patients then do very well with cyclosporin. And of course, the cyclosporin dose needs to be titrated. These patients have to be worked up for use of cyclosporin. We use very, very low doses of cyclosporin in these patients, not the doses that you use in transplant patients. So these are the significant changes that have occurred recently. So what omalizumab does is that it binds to the IgE molecule and decreases the expression of the high affinity receptor, both on the IgE, on the long chain of the IgE, as well as on the mast cell receptors. The clinical response is extremely fast, and most patients respond within 24 to 48 hours following a single dose or 300 milligrams, which means 2 vials of omalizumab. You can see from this study, compared to placebo, and this is placebo, your patients on 300 milligrams of omalizumab have a significant reduction in the weekly itch cause. And this persists throughout the study with 300 milligrams of omalizumab. There are various other biological therapies that have been used, but nowhere as near effective as omalizumab, such as anti-IL-1 therapies, phosphodiesterase 2 receptor antagonists have been used as well. They haven't been very effective in these patients. Before the availability of omalizumab, we sometimes used to use intravenous immunoglobulins, such as Polygam, with mixed results. And of course, there's a huge cost associated with it. But most of these studies are mainly case reports. There are no proper randomized control studies with these different treatment modalities. The new kid on the block is ligelizumab. Ligelizumab, and I'm involved with a study at the moment with ligelizumab in adult patients. And this is a double-blind study comparing ligelizumab with omalizumab. And this is a humanized IgG1 monoclonal antibody that binds with high affinity to the C epsilon 3 domain of IgE. Now, compared to omalizumab, ligelizumab shows a 6-fold to a 9-fold greater suppression of allergen-induced skin prick tests in vivo, and it is a much more potent drug than omalizumab. We're now doing the open-label study for ligelizumab. We've done the 1-year double-blind study. We're now doing the open-label study. And these patients had an interval of 2 or 3 months where they were on no treatment at all. And I can tell you that these patients come in with severe wheel and flare reactions. They're covered with urticaria. The moment they get the injection, within 24 to 48 hours, the symptoms are gone completely. What we've noticed with ligelizumab compared to omalizumab, in that the effects last much longer, and this may also decrease the cost of medication, because one of the biggest obstacles to treating these patients is the cost of these medications. And unfortunately, pharmaceutical companies are not budging as far as the price is concerned, because there are thousands of patients that actually need these medicines. So how do patients with chronic spontaneous urticaria do? So studies have shown, so it's a very simple rule, 15% of patients have chronic spontaneous urticaria for life, 25% of patients have it for 1 year. The majority of patients have it for 2 to 5 years. So which patients do well and which patients don't do very well? Now, studies suggest that although the duration is likely to be between 1 and 5 years, it is likely that those patients who have more severe disease, who have concomitant angioedema, who have concomitant inducible urticaria, and have a positive autologous skin prick test, which I've showed you, do worse and have a longer duration and poor prognosis, and also a poorer response to many of these biological treatments compared to patients that don't have these concomitant comorbidities. So 50% of patients will resolve within 6 months of onset of chronic spontaneous urticaria, 20% will resolve within 3 years, 20% will resolve within 5 to 10 years, and a few
The whole week went with it.
A small percentage of patients may have it for life, and it may take up to 25 years for them to have resolution of their symptoms. So this is my last slide. The aim of therapy for chronic spontaneous urticaria is quick and complete symptom control. The international guidelines, which were published in 2013 and 2017, advocates the use of your second-generation antihistamines at licensed doses. If patients fail to respond, then you should up dose the dose of these antihistamines to fourfold the dose. We also have newer drugs now, such as rupatadine. And if these patients fail to respond to higher doses of antihistamines, then omalizumab should be your third-line treatment. 20% of patients will fail to respond to omalizumab. These patients may be candidate for cyclosporin. I thank you for your time and attention, and thank you to IMA and Novartis for giving me this opportunity to share my thoughts with you today. Thank you very much to an audience that have stayed on for almost 1.5 hours listening to both the speakers. Jazakallah khairan.
Shukran, Dr. Manjra. Shoaib, would you like to show the video from Novartis while Dr. Manjra reads some of the chat questions? And while you're loading it up, I'd like to thank both speakers for giving up their time. And this is the webinar that was attended by most delegates so far. So you can see we've still got an audience. Even after 2 excellent speakers, look forward to an excellent Q&A. Shoaib, are you able to share your video? Dr. Manjra, I think you just need to stop sharing your screen.
Okay, sorry.
We'd like to introduce you to the Breathing 365 app from Novartis. This video will show you how to download the app in 5 easy steps. But first, let's take a moment to tell you why you want it. Breathing 365 gives you excellent, engaging, bite-sized asthma and COPD medical educational content, presented by international clinicians and scientists. This content will help you keep up to date with key topics and support your efforts to provide optimal care for your patients through easy and accessible ongoing learning in respiratory medicine. Now to get it on your phone. 1. Open your camera and scan this QR code to go straight to the download option on your device. Otherwise, go to the Apple Store or Google Play and download the Breathing 365 app by Novartis. 2. To register, press Get Started, then choose your user type. 3. Fill in the fields, accept the privacy policies, and press Continue. 4. You will receive an email. Click Create My Account, and you will be redirected to the app. 5. Just hit download. It's that simple. Now you have Breathing 365 and can continue your asthma and COPD learning at your convenience. Remember, there's new content all the time, so regularly check for updates.
Thank you so much. We'd like to start off with a question to Ismail Kala. Ismail, could I ask you, maybe from the cardiovascular part, when is it safe to give a beta blocker to a patient with asthma, and which would be your choice of a beta blocker?
Assalamu alaikum, Ahmed. So that's a very interesting question, right? In my experience, and I say this with a lot of trepidation, I don't know that there's a safe beta blocker that one can use in a patient who's got pure asthma. Now, that might not be true for our COPD patients. However, the literature and the landscape with the use of beta blockers in COPD is also changing somewhat. But what I've noticed is that, you know, in the different asthmatic phenotypes, and it really depends what type of asthma phenotype you're looking at. And if you've got a Th2 high asthma phenotype or eosinophil-driven asthma phenotype, then beta blockers, even instilled in eye drops, can have adverse, bronchospastic responses. So my advice to the audience would be, outside of a specialist clinic, to use beta blockers with caution in patients with true asthma. That being said, you know, in the presence of a controlled environment, or maybe a clinical drug trial where patients are regularly followed up and have easy access to emergency facilities, then a highly selective beta blocker like nebivolol might be a therapeutic option, but I would still use it with trepidation.
Isma, while we have you on, there was a question of which, or Montelukast, which would be, is it useful, number one? And when do you start it, especially now that we've just passed this, the seasonal allergy month, when do we start these agents? Would it be in December, or do you just start it when the season changes?
So again, a very good question. If we look at the GINA guidelines, in the management of basic asthma or just simple asthma, stage 1 and stage 2, Montelukast is actually registered for add-on therapy in the adult patient. Right? In the pediatric patient, you can use it as first-line symptomatic therapy, but then again, the head-to-head trials with the inhaled corticosteroids showed inferiority. That was the last time I reviewed the pediatric literature, and Dr. Manjra can correct me on that. So inhaled corticosteroids are still by far the superior therapeutic intervention. When used as add-on therapy, then it would depend on one of two things. One, it would depend on the presence of nasal symptoms. So do they have a significant amount of nasal rhinitis or chronic sinusitis? And in those patients, Montelukast is fantastic. And then again, exercise-induced asthma. Montelukast seems to play a significant role in the modulating of the inflammatory response in exercise-induced asthma. However, you know, when we're looking at exercise-induced asthma, it means that you have to be on Montelukast chronically. You can't take a tablet before you play a game and expect it to work. Whereas you can use, you know, a MART regimen just before a sporting activity, and it is registered by WHO for the use in athletics as well as international sports in patients who are diagnosed with asthma.
Dr. Manjra, while you have a lot of experience with Montelukast, when do you start it for your patients with Urticaria pre-seasonal pre-season?
Okay, so here we're talking about Montelukast for asthma. I think in pediatrics it has a much greater role to play than in adults. We've just recently published the guidelines in the SAMJ in May 2001. And our consensus of the role of Montelukast is that it can be used as first-line therapy in patients with mild to moderate asthma. In patients with moderate to severe asthma, it's added on as add-on treatment. Montelukast is also licensed and registered for use in allergic rhinitis as adjunctive therapy through intranasal steroids as well as antihistamines. So if you've got patients who are on intranasal steroids, on high doses of antihistamines, and now there's a new intranasal steroid which has a topical antihistamine combined with it. If they are not responding to this particular treatment, then many of these patients do very well with Montelukast. In addition to the exercise-induced symptoms which Ismail has spoken about, Montelukast also works very well for aspirin-associated respiratory disease. It works very well there. So in children, it has a much greater role to play. We use it both for persistent asthma as well as for intermittent asthma. So that's my part as far as pediatrics is concerned. I hope I haven't left anything out. As far as the use of montelukast in urticaria, I have found it to be an extremely disappointing drug. And most patients respond very poorly to montelukast. They do much better with higher doses of antihistamines and omalizumab, which we're now using much more than before. It's becoming more accessible to patients.
Thank you. Let's answer one question quickly towards the end. It was asked, what's your experience of methotrexate, Dr. Manjra? So methotrexate as therapy in chronic urticaria.
So methotrexate has been studied for chronic urticaria. It is part of the algorithm in patients with urticaria. It's a much safer option than cyclosporin. But it is not as effective as cyclosporin. It's not as effective as omalizumab, but it can be used in patients. It's a much cheaper option. Omalizumab is very expensive. It's like almost 10 grand a shot. Cyclosporin is also expensive at the doses that we use for chronic spontaneous urticaria. Of course, methotrexate is a much cheaper option. So in patients that are unable to afford these two drugs, I would suggest methotrexate as an alternative to these drugs. And they have a mixed response. Some patients respond very well and some patients don't respond very well. There are no randomized controlled trials with methotrexate in patients with chronic spontaneous urticaria. Most of them are case reports.
A question, Dr. Manjra, that came up from one of the audience was a 45-year-old male patient that had a general itch that was triggered by a full bladder. They just wanted to understand the mechanisms.
Yeah. So my only answer to that is try not to have a full bladder. Just keep on emptying your bladder. I'm not sure what the mechanism there is. I've never heard of that. So I have no idea why that patient gets urticaria with a full bladder and is relieved by emptying the bladder. I have no idea. I've never heard of that phenomenon before. And then I think there was another question about stress-related urticaria. I think I've mentioned in my talk that stress is never the cause of urticaria, but it's an aggravating factor. So these patients have underlying urticaria, they have chronic spontaneous urticaria, or they may have one of the inducible types of urticaria. And of course, stress aggravates it and makes it worse, like most other conditions like hypertension and asthma and diabetes and atopic eczema. So stress certainly has a trigger role to play, but not a causative role to play.
Thank you, Dr. Manjra. Going back to Dr. Kala, Ismail, the questions, we'll deal with the COVID question just now. Is statin therapy advised in patients with asthma?
Ahmadji. So the question that's been asked in terms of as adjunctive therapy in patients who've got dyslipidemia or as primary therapy for bronchial airway hyperactivity, Ahmed?
I think it got as an anti-inflammatory, not for dyslipidemia.
Okay. So there have been one or two trials, and there's still one in the Cochrane database. No evidence of any benefit, unfortunately. So the pleiotropic effects of statins seem to be related more to the endothelial lining rather than the epithelial lining, which we see the main focus of the asthmatic airway response is targeted against. And secondly, we see it more on its pleiotropic effects again on antiplatelet or antiplatelet effect. And we don't have much of a platelet-related illness in patients with asthma. Just pathophysiologically, I don't see how it will be of much benefit. And then again, none of the trials have shown to be it to be of any benefit as an adjunctive therapy at the moment.
Okay. A question that came in from one of the pulmonologists. Also, maybe we'll just discuss it. And it was a question post-COVID. Are you seeing a lot of reactive airway similar to asthma? And you've just given us a description or an answer to that. Do you just want to say a few words on that, Isma?
See. Yeah, so Ahmed, what we've seen, so Shiraz has asked the question, and Alhamdulillah, it's a very good question, right? We've seen a lot of patients who present to us long COVID with shortness of breath, persistent airway symptoms, sometimes a bit of a wheeze, and we don't know how to really approach those patients. They are significantly impaired by their inability to maintain a normal functionality. And whether the shortness of breath is coming from a cardiorespiratory perspective, organic cardiorespiratory disease, or whether it's coming from post-traumatic stress disorder is very difficult to tease out. So what we're seeing is that we are seeing, but in my experience, it's been the minority of the patients. So the patients who had long COVID, who had severe long COVID, those patients who, myself and Shiraz have been treating significantly, are the patients who've been hospitalized and probably spent a lot of time in ICU. Those are the patients who've got long COVID lung fibrosis. That's a parenchymal, or rather an interstitial lung disease, and it's a completely different animal. It doesn't present with bronchial airway hyperactivity. Most of the patients start off with baseline lung functions, 40 to 50% of pre-COVID capacity. And those patients we don't have any guidance, but we manage them predominantly as if they, interstitial pulmonary fibrosis like patients. However, in the mild COVID, which is the majority of the patients that myself and Shiraz have not seen, those are the patients that were managed either at home or by district healthcare nurses or by general practitioners in their house. Those are the patients who, because for several reasons, and we know definitely one is that there's an organic element to it where COVID actually modulates, neuropsychiatric representations of illness and causes and exacerbates, anxiety in these patients, and definitely, fear of death, fear of losing loved ones will definitely cause PTSD. And my feeling is that most of the normal COVID patients, or those patients that we do lung functions on and the lung functions are normal, we see a normal chest X-ray, and are complaining of severe airway symptoms, then those are less likely to have bronchial airway reactivity and more likely to have PTSD, post-traumatic stress disorder. Ahmed, you're muted.
Thanks, Ismail, for that. Before we go to the question on vaccines, Dr. Majra, a question that came on from the alternative aspects of the herbal part of allergy and I suppose a bit of Islamic background. What's your thoughts of Kustul Hindi and these alternative therapies for allergies and immunological basis of this? Have you got any experience, or where would one explore this field further?
I don't know. I'm not a homeopath, and I don't understand any medicine except allopathic medicine. So, people try various things for urticaria because many of them are very, very desperate. I have one patient that was smoking cannabis, and he swore to me that his urticaria disappeared completely, and when he stopped smoking it came back. So people have various kind of conceptions of treatment and pathophysiology of urticaria, but we know it's an autoimmune disease, and we know it also undergoes spontaneous remission in many of these patients, and that may be coincident with them taking a particular type of treatment. So look, what I've spoken in my talk is evidence-based antihistamines, omalizumab, cyclosporin. The rest of it is not evidence-based.
So thank you, audience. You've heard it from the experts. No rash decisions. Ismail, let's ask you the question first. The question is regarding COVID vaccines, and particularly let's try to focus it only on kids. So let's do the 12 years to 18. Today I've seen a patient that came in with a probable pericarditis post-vaccines. And I've even seen patients, young patients below the age of 20 with myocarditis, pericarditis, MRI proven just from COVID itself. And we all follow evidence-based medicines, and we do recommend the vaccines. Maybe we just like some advice as a pulmonologist, as a person in critical care in the front line. What's your feeling on COVID vaccines in under 18s? And if you want to specify further age group, you can further elucidate. Shukran.
Yeah, Assalamu Mohammed. So you've seen the data that's been published from the United States, right? So there's basically definitely a signal for the use of vaccinations in the 12 to 18-year-old age category, and COVID-induced COVID vaccine-induced myocarditis. At the moment, the pathogenesis behind the myocarditis is not clearly understood, right? But there's definitely a signal. So the question that we need to ask ourselves is, why are we advocating vaccines in this age group? We've never ever seen severe COVID in this age group. We've seen a sporadic amount of COVID patients in the high risk individual, those patients that have got chronic cardiorespiratory illnesses, the morbidly obese patient, the patient who looks like an adult, although he's, you know, an adolescent. In those patients, then clearly there is a benefit from using the COVID vaccine. But by far and away, the majority of the adolescent group and the impetus for using vaccine in this particular group is to try and accelerate herd immunity. So what we're trying to do, what the epidemiologists are trying to do is by creating or breaking the natural reservoir of COVID within the children, that the spread would actually decrease. Now, there's some merit to that. There's some what we would call altruistic benefit to the rest of the community by trying to break this particular pattern. However, this needs to be balanced against the individual risk for the patients, you know. I don't know, you know, you asking, I think the literature, we just started the rollout. It's still very early. The signal might become much more stronger as time progresses. We might find that there's also an induction of autoimmunity in these patients. So I don't know, you know, I think the immune system is very immature. I think that their bodies are very immature. They're still going through a significant amount of hormonal transformations. And especially in females, the high estrogen spurges that occur at the time of menarche can definitely, you know, contribute to an autoimmune milieu in the presence of a mRNA vaccine. So I think there are a lot of questions, more questions unanswered than questions answered. What I do understand is the rationale and the altruistic rationale behind using it, but I don't know that I would, at this particular moment in time, advocate for it until the literature is much more, you know, robust.
Thank you, Ismail. Dr. Manjur, as a pediatrician, what's your comments on the vaccines and kids?
So I'm going to be a bit controversial here, okay? And, you know, people can disagree with me. And I've been asked this question probably a couple hundred times in the last couple of weeks since the vaccine became available for 12 to 18-year-olds. So what do vaccines do? What does a COVID vaccine do? COVID vaccine is very different from the other pediatric vaccines that we are familiar with, like diphtheria, tetanus, polio, whooping cough, and so on. Those vaccines have more than 90% efficacy. They're extremely safe. They prevent disease. The COVID vaccine does not prevent disease. What it does is prevents severity of the disease. It prevents hospitalization. It prevents severe disease. It prevents death. But it doesn't prevent COVID. And that's been shown now in the UK as well as in Israel and many, many other studies. So definitely it has a very significant role to play in people over 18 years of age who have comorbidities and who are at risk of severe disease. We have seen many children with COVID, very few admissions, very few deaths, very few with severe disease. So the complication that we see in adults, we do not see in children. Everything in medicine is risk and benefit. The risk of myocarditis is higher than getting a risk from COVID in children. So the risk of getting myocarditis is much higher than the risk of developing severe complications from COVID in children. So to me, the risk at this point is much higher giving the vaccine than not giving the vaccine. That's the first thing. Secondly, as far as herd immunity is concerned, that will happen if you vaccinate most of the adult population, because what happens is the virus will then move towards populations that are not vaccinated, which is children. They will acquire natural immunity, mild disease from natural infection. And just last week, it's been shown in a study that natural immunity is much more longer lasting than vaccine immunity. The immunogenicity that you develop from natural infection is much more longer lasting than from a vaccine. So these children will get infected, and they will then confer herd immunity to the rest of the population. The other thing I don't understand is that we know that for the vaccine to be effective, you've got to give 2 doses. The government has only advocated 1 dose. You cannot get immunogenicity with 1 dose. If you get partial immunity with 1 dose. So again, I think that's a very ill thought out, illogical, vaccine rollout in 12 to 18-year-olds who are at very low risk of developing severe disease. I don't think herd immunity will work in these patients. And we know that vaccines do not prevent transmission of the virus. That's my view at this point in time. I have not seen a convincing randomized controlled study in the literature. I've looked very hard in the last few days, which clearly shows the benefit of vaccines in 12 to 18-year-olds. As far as 18-year-olds and above is concerned, I think that the evidence is incontrovertible. The vaccine works, it does prevent serious disease, but I have serious reservations about giving my patients, my grandchildren, vaccines from 12 to 18 years of age. Others may disagree. I think the jury is still out. I think we should wait for in the next few months to see what really happens, how this whole thing evolves with time. And I think we'll get a much more clearer picture in the next few months, or maybe next 6 months or so, when more studies are done, where the numbers are more robust, where you can clearly show a benefit for vaccinating for vaccinating children. That's my view at the moment. My view is, in summary, the risk outweighs the benefit. In adults, the benefit outweighs the risk, and therefore I'm not advocating vaccinating children at this point in time. My views may change as the evidence evolves with time.
Thank you. I think it's such an evolving field, and we're all here to learn. And I think these webinars are an excellent platform to discuss these issues. Ismail, the last question that came up was these long COVIDs, and we see these in our ICUs, difficult to ventilate. They behave almost like a restrictive lung disease pattern. I mean, you've been in the front line. We've seen what COVID can do. Your comments on how just regarding this long COVID and respiratory ventilation?
So the question, I've read the question, and I was going to actually, I'm glad you give me an opportunity to speak the answer, because it's quite a difficult question to address. So the first thing that, in any patient who's got long COVID, one needs to phenotype those patients. We're moving towards more individualized medicine, right? And even with COVID, we phenotype our patients based on what the cardiac pathogenicity of the virus was on the patient, and then on what the respiratory pathogenicity was. And what we've seen in the long COVID patients is we've seen clearly 3 different types of long COVID. We've seen the patients who have predominantly airway disease, which is similar to what Shiraz asked about, bronchial airway hyperactivity and asthma-like symptoms. Then we see in the patient who's got some form of alveolitis, or rather ground glass pulmonary infiltrates, and they look like, given time, those particular patients will actually resolve with the appropriate immunosuppressive therapy. And then we get the third type of the patient, which is basically the chronic progressive interstitial fibrotic COVID patient. Now those patients we have to wrap up in a ball of cotton wool. So those patients, any further insult to the lungs will actually accelerate or exacerbate the underlying inflammatory milieu that's actually promoting this fibrotic transformation. So basically, you have a switch, from a type 2 alveolar pneumocyte into a myoepithelial cell, and then that undergoes further transformation into a fibroblast. And you have a significant amount of collagen that gets lays down in the alveolar space, and that eventually causes the alveolar space to become obliterated. Now, if you then add injury to that insult in any form whatsoever, especially in the way of positive pressure ventilation, without doing a baseline lung functions first to see how severe those patients are, you might end up with a patient that you'll not be able to extubate on table. So for me and these long COVID patients, one has to then again, as Dr. Majra said, risk stratify benefit versus risk for elective surgery. What type of elective surgery? Is it oncological? Is it important? If it's orthopedic, I would defer it. But if it's vitally important and undeferrable surgery, then my feeling would be to ventilate those patients as gently as possible, to go as much as possible for regional anesthesia, and if that's unavoidable and unusable, then to use ultra protective modes of ventilation to try and protect the lungs in those particular patients.
Thank you, Ismail. We'd like to close off the session and just like to thank Dr. Manjra and Dr. Kala for really your guys' expert opinions. Thank you for taking up the time. Thank you to Novartis for the sponsorship. Thank you to the IMASA family for this family of beloved colleagues. Thank you for engaging, and we look forward to many more further discussions. To welcome you to the next webinar. It's on the 10th of November. and the topic would be on antacids and reflux by Dr. Raymond. We'd like to close the meeting with Surah Wal-Asr, and thereafter any further questions or suggestions, please forward to Kashifa. We'd like to ask your opinions on what further discussions or topics you'd like. Thank you all for attending. Obviously, this is CPT accredited. We thank you for your time. Bismillahir Rahmanir Rahim. Wal Asr. Innal insana lafi khusr illa alladhina amanu wa tawasaw bil haqq wa tawasaw bis sabr. Assalamu alaikum wa rahmatullahi wa barakatuh.
Right.